Good evening. Let's begin with a prayer. In the name of the Father, the Son, and the Holy Spirit. Amen. Eternal Father, during this holy season of Lent, invite us to turn our minds and hearts to you, that we may walk in your paths, know your peace in this life, and eternal joy in the life to come. May all who suffer pain, illness, or disease be joined to Christ in his suffering for the salvation of the world. May the information presented this evening help our parishioners and their families know that in Christ and through his church, they are accompanied, loved, and supported in their serious illness and end-of-life journey. We ask this through Christ our Lord. Amen. In the name of the Father, the Son, and the Holy Spirit. Well, good evening. I'm Father John Shimos, our pastor at St. Anne's. On behalf of Marianne Barnes and Sharon Stark, who lead St. Anne's Whole Person Care Initiative, I welcome you to this evening's presentation on palliative care. But first, allow me to make 3 introductions. If you'll come forward so that those who are watching this on video can see it. The first is Rebecca Freeman, the Pastoral Care Ministry Coordinator, the Office of Family Life, Diocese of Orange. Thank you for joining us this evening. Patty Barnett-Bouton, the Vice President, Outreach and Advocacy at Alzheimer's Orange County, and a member of the Leadership Council of the Diocese of Orange Whole Person Care Initiative. Come closer to the field of vision, right in front of the, come in front of the screen, both of you, please. That'll work. Thank you. Thank you. All right. Thanks. And Dr. Vincent Quinn, the Palliative Care Program Director, Medical Director at Hoag Hospital, who's also recognized as this year's Orange Catholic Foundation President's Award for Catholic Community Leader of the Year. Thank you for joining us this evening. Thank you.
Thank you, Father John. Thank you very much, Father John, for having me here, and thank you to all who are here this evening to bear the cold and 6:30 evening spare your dinner with us. I'm pleased to be here, and I'm just going to jump right in to talk about this caring for the whole person. This is a collaborative project, as you may have heard, between the California Catholic Conference of Bishops and the Alliance of Catholic Healthcare. How the ministry, as well as the mission of caring for people who are living with seriousness in our community. We want to make sure that Catholic institutions have palliative care. And we want to make sure that our dioceses and our parishes have programs such as today to understand what the church teaches about end-of-life care and how do we as a caring community work and care for those who are frail, who are alone, who do not understand what is available for them. The program that I'm presenting tonight is just only one brief portion of what this whole caring for the whole person is about. I'm just giving you a highlight. So hopefully you enjoy it, you can come and join us. It's about a 5-week project. So my talk today is on the palliative care options, a Catholic perspective, and I share this stage with Patty Mouton, who you just met, and I'm Dr. Vincent Nguyen. That little emblem there is with the Order of Malta. I'm a knight in the order, and we care in how God brings everything to a full circle. What the Order of Malta does is to care for people with serious illness. And when you hear the word hospice and how hospice was started in the middle part of the middle part of our 11th century, how hospice was started. It was started by the order as well, and caring for people, not necessarily at the end of life. It was caring for people who were going on pilgrimage to the Holy Land. They were sick and they needed a place to stay. This is what the order did. But also, when people are going on pilgrimage, they get sick and they die, and then the folks take care of them there too. So, how God brings everything together. I'm just flattered to be a part of this whole organization and bringing palliative care into our community. And I've been doing this work since 1994. It was not something that I went into medical school and said, I'm going to be a palliative care doctor. It just caught me from out of the blue. I was trained in family medicine and geriatrics, and and caring for people at the end of life just plopped in my lap. And when I started doing this work, I felt it was like a hand in glove service. And I remember going home to my wife, who was working in hospice. I told her, if I made enough money to do this work, I'd volunteer to do it, because it just doesn't feel like work. It's really about caring for people. So our purpose this evening are threefold. We're going to answer, what is palliative care? You hear this word all the time, and people have misunderstand what it is. And then we're going to answer the question, does the church require Catholics to pursue all efforts to preserve life? Just with that long question, you kind of know it's going to be no, right? And how do we prepare for our end-of-life options? So this is a little bit small, so I'm going to read it to you. So what is the church teaching on palliative care? This is from Pope Francis' message to the European Regional Meeting. He says, let each of us give love in his or her own way, as a father, a mother, a son, a daughter, a brother, a sister, a doctor, or a nurse, but give it. And even if we know that we cannot always guarantee healing or cure, we can and must always care for the living, without ourselves shortening their life, but also without futilely resisting their death. This approach is reflected in palliative care, which is proving most important in our culture, as it opposes what makes death most terrifying and unwelcome: pain and loneliness. So the teaching of palliative care in the Catholic Church is about caring for people. So it's a special form of selfless love, and such it should be encouraged as defined in our Catechism of the Catholic Church. So let's talk about what palliative care is. You're welcome to take pictures of my slide, and you like to copy my slide. I'll send it to you in a form. So what is palliative care? So palliative care is specialized medical care for people living with serious illness. I'm going to take a pause here when we say specialized. What is so special about it? Well, it's so specialized that doctors spend an extra year after their residency to do a fellowship. So if it's just about death and dying, why would a doctor spend an extra year after their residency to talk about death and dying? It's about how to help people live with serious illness. Medicine technologies have gone such a long way. And so I teach at UC Irvine. I helped founded I was one of the founder of the Palliative Medicine Fellowship at UCI, where we train doctors. This past year we had 80 applicants for 2 slots. So these doctors were neurologists, cardiologists, emergency physicians, besides hospitals, emergency medicine, internal medicine. So people are clamoring and saying, we need to utilize this skill so that we can better care for people living with serious illness. So it is the goal of palliative care is to improve the quality of life for the patient as well as their family. Because when someone is sick, it's just not about that one person going through the illness, but it affects the entire family. It affects their caregiver. So how do we care for the entire unit? And it's appropriate at any age and any stage of serious illness. So you don't have to be 80 years old to receive palliative care, and you don't have to wait for so long. You don't have to wait until you're at death's door to receive palliative care, right? So people living with serious illness is really, when you live with a serious illness, well, living is a serious illness, because if we look at it, you look at the percentage, 10% of people die with sudden death, right? We get a massive heart attack, we get an accident, we die, 10%. That means 90% of us will die of a protracted, prolonged illness. So while medicine is so good at treating the acute situation, but our disease becomes chronic. So it's just at the end of life. And I was speaking to Father John. You're going back and forth between the nursing home and the hospital. At some point, enough is enough, right? People living with chronic illnesses, and they die with their serious illness. We just don't know when. And focus on providing pain and symptom management and stress from the serious illness. That's what palliative care is. When you're sick, it affects you as a whole person. It affects you not only physically, but also emotionally, psychologically, and spiritual. So these are the spiritual distress that people are going through. And the beauty of palliative care is, I love this slide, is because we see the person behind the disease. We see the dancer behind the cancer. And that's what the slide shows. So let's talk about the important distinctions. And when we talk about palliative care, you hear about end of life, you hear about hospice. Or isn't it all the same? You know, I hear people say, when they hear palliative care, I say, no, I don't want palliative care because that's death and dying. And as you hear about, we talk about, why does doctor go into a fellowship for a year to talk about death and dying? Because we really want to focus about living, how to help people live well and live long with their serious illness. This is training. But it's in palliative care, when we help people live long, we have yet to solve the issue of immortality, okay? And maybe it's good, maybe it's not so good from our Catholic perspective. But then how does hospice fit into all these? So you can see that when you look at this, palliative care is this big umbrella term in caring for people, relieving the symptoms and distress of a serious illness. And you see the end of life care is only one proportion of what palliative care is. And within that end of life is called hospice care. It's rendered for patients who has a limited prognosis of less than 6 months. So when you look at the slide, you'll see hospice care is palliative care because it falls in the big umbrella term. But palliative care cannot be shrunk down to it's just hospice. So hospice is a specialized palliative care for people living with a terminal illness with a prognosis of less than 6 months if the illness follows its natural course. That's hospice care. Palliative care, you live with a serious illness, people are still seeking treatment for, let's say you have cancer, you still can go to see your oncologist, you get your treatments, and palliative care is there to help with symptom management, right? People have pain, they have nausea, they have vomiting, they have anxiety, they have depression, they can't sleep, they're constipated, they have diarrhea, and then they have family members who are distressed, they're distressed. So it's about caring for the whole person. So you don't have to give up treatments to receive palliative care. But when someone is at the end of their life where the treatment is no longer working, you can have more treatment if you want, but it's not going to change the outcome. It may cause further suffering. And the beauty of hospice care is that it provides that care for people in the last stage of their life, and it also focuses on living. Hospice is about caring for people with their terminal illness and how to help them live whatever time they have left. Okay, any questions? This is a very important slide. And I try to make this as simple as I can, okay? All right, so hospice is a specialized form of palliative care, okay? But it's not palliative care all on its own. So palliative care is a hallmark of Catholic health care. Why do we call it a hallmark of Catholic care? Because we realize that our vocation and of the Church's teaching is to reach out to care for the sick, the vulnerable, the marginalized, the poor, the dying. This is how we serve, this is our Catholic teaching. And then the part of the teaching is that, we care even though we cannot cure. There's not a whole lot of things that we can cure in medicine. I'm going to use the term, use the word of, doing an appendectomy, right? The person comes in with right lower quadrant pain, find out they have a ruptured appendix. Well, the surgeon will take that out, you get a cure. But if someone who has congestive heart failure or pretty advanced COPD, there's no such cure for that. Or people living with dementia, there's no cure for dementia. We can only give medicine to slow down the disease. And there are some good days and some bad days, and how do we manage those symptoms for the patients? But however, as good as the hallmark of palliative care, consistent with social teachings of the Catholic Church, there are some key tensions between what the Church teaches and what the priorities in our societies. We see that life within our Catholic tradition, life is a gift. Life is a gift from God, and we are all stewards of that life. And so being a steward, there's a limitation to that too. Being a steward with our life does not mean that I'm depressed, I'm anxious, I need something to help end my life. And yet at the same time, being a steward does not mean that I have to do everything to prolong my life. And because dying has meaning and purpose, when we're at the end of stage of our life, we're at the end of our life, you don't have to do everything just for the sake of living. So death is a personal completion of our journey. We know that death is a gateway when we look at what is the purpose and meaning of life, it's not to be born and we die. I mean, for us, our teaching is when we live on this earth, we live a good life. We help others, and then we prepare to meet God. So at the end of our life, our goal is to see God face to face and to be with Him forever. That's what our tradition teaches us. Society has a different priority. It sees that life is a possession. It's my life, it's my body, it's my choice to keep away. Dying is destructive. Death is there. It's, somebody has failed. So it's a failure of professional duty. Somebody is at fault when my loved one dies. So this is the tension around end-of-life care. But the reality is everyone dies. Death is not an inherent failure. I call it, however, neglect. Neglect is an inherent failure. Yeah, I'm sorry, that's the hospital. I just have to wait. Neglect is what do we neglect? So let's talk about what the church talks about with the ethical duty to manage pain. I'm going to read this to you. What is hardest to face is the process of dying itself, especially the dependency, the helplessness, and the pain that so often accompany terminal illness. One of the primary purposes of medicine and caring for the dying is relief of pain and suffering caused by it. Effective management of pain in all its forms is critical in the appropriate care of the dying. So, when people are dying, the last thing we want to do is have them suffer. You'd be in physical torment, emotional torment, or spiritual torment. When we relieve pain and suffering, it's just not about giving people a bunch of morphine and Dilaudid or hydromorph or whatever it is that we're giving people, but really need to pay attention to the entire suffering that person goes through. Not just the physical, but also the emotional, the spiritual, the psychological, and the social, how this dying process can affect the loved ones and the caregivers. How do you make peace with this? So medicines capable of alleviating or suppressing pain may be given to a dying person. Even this therapy may indirectly shorten the person's life, so long as the intent is not to hasten death. So while it is our ethical duty to manage pain, we have to push the medication to ensure the patient's comfort, with the intent that I'm not pushing the medication to end your life. I'm going to give you medication proportionate to the amount that you're suffering from, so that at least I can give you some comfort. And this is something I tell people all the time. Sometimes patients tell me, I don't want to go on morphine because I don't want to be addicted to morphine. I want to be psychologically dependent. And I said, well, mom is dying from metastatic breast cancer. It's gone to everywhere. I don't think being addicted to this opioid is going to be a big deal, right? Addiction is a psychological dependence in which patients will lie, steal, cheat, and do whatever they need to get their fix. This person is suffering. Why are we withholding treatments from them? Because that causes unnecessary suffering for the patients who's living, who's trying to live whatever time they have left well. Okay. So I'm going to go back and talk about a little bit of a responsible stewardship. So that means stewardship of our life means we're not doing anything to hasten our death, and no, we're not going to do anything to prolong the dying process. So within palliative care and within hospice, we're there to journey with people living this serious illness and being a guidepost to those family members who've seen their loved one at the end of their life. So we're giving medications proportionately, not underdose them because we're afraid we may cause respiratory failure, and we're not going to push the dose in such a high amount that let's just put them out of their misery. Right? It's about utilizing the medicine appropriately. This is why doctors spend that extra year to understand what does that mean to use a medication proportionately. What does it mean to have these conversations with patients and family? So Pope Francis, again, we're going to utilize a lot of his teaching here. In November of 2017, to the European Regional Meeting of the World Medical Association, he says that it has also become possible nowadays to extend life by means that were inconceivable in the past. Surgery and other medical interventions have become ever more effective, but they are not always beneficial. I'm going to read that again. All these medical interventions have become more effective, but they are not always beneficial. While they can sustain or even replace failing vital organs, but that is not the same as promoting health. Okay, we can keep the organs alive, but it's not promoting health for the person. Greater wisdom is called for today because of the temptation to insist on treatments that have powerful effects on the body, yet at the same time do not serve the integral good of the person. That's pretty deep, right? It talks about, while we can do everything to a person's body, but are we promoting health? Or are we causing more suffering to the person? So medicine has a temptation, as doctors, we go into medicine, as a medical student, as an intern, we think that, we can care for everything. We can cure anything that we want. That's why we went to medicine, right? Because, I'm gonna find a cure for cancer. I'm gonna, find a cure and take care of all people's ailments. But as you practice long enough, you begin to be humble, as I learned in my 30 years, that, there's still a lot of things that I don't know. The more I know, the less I think I know. So, but so what is the theological foundation of all this? What does our faith teach? Well, faith teaches that we are not God. Okay, we are the creature, not the creator. We are human and we're not divine. We're finite and not infinite. So we must avoid two types of idolatry here. If we're not God, but then we think we're God. Sometimes as doctors, we think we're God too, with a little G, of course, because if someone's dying from me, I'm going to go and save your life. If I did that, I'm God. But the problem is, when we try to do this, we usurp God's power by attempting to kill or destroy life. When life ain't worth living anymore, I will help you die, but I will give you big, strong medications. There are doctors out there specializing in helping people die by giving them big doses of medicine to end their life because the patient feel that their life isn't worth living anymore. And these doctors are very quick in saying, okay, yeah, you're right. Let me put you out of your misery. Let me help you because I'm a compassionate doctor. And we playing God doing that. And I said, yeah, you are. And then at the same time, when we play God by attempting to prevent death, but not promote dying well. We're going to use all the technology we can just to keep the body, the organs alive, but the person is no longer there. We're not promoting health. We're just doing things just because we can and we can get paid for it. Okay, and then attempting to keep alive but not to help people live. So this is the theological foundation. It becomes extremely important. We're not God, and we're not going to play God. But we're going to do everything we can to use our skills, our understanding to help people in their journey of their illness. So when faced with a serious illness, the question that we ask ourselves is, what are my priorities besides just living longer, or just besides survival? I want to live, but what are my priorities? What do I value most? What are my priorities? And one of the things that we don't do is we don't ask ourselves that. And as I help train other doctors, I said, how do we know what our patients want when we don't talk to them? When we don't sit down and have these conversations with our patients to seek their values, seek their preference, seek what's important to them. Because yes, they come to us and yes, doctor, help me get through my illness, help me live, but what are you willing to endure for the sake of more time? This is a tougher, deeper question. So what do I value most? What are my priorities? But sometimes we're going to go, well, we hope that doesn't happen. Well, the problem is hope is not a plan. Okay? You can hope all you want, but it's not a plan, because in medicine, I said, doctors play God, right? So when a plan is unclear for us, as default is we're just going to treat. If you don't have an advance directive, you don't have you don't tell us what is important to you. Paramedics come to your house and you find a loved one on the floor. Their responsibility is, let's treat aggressively to help this person live. But what if this person has a terminal disease? They don't want any of these treatments. How do we know? So we need to make clear that we hope that it doesn't happen, but we have to have. This is why we're here tonight. We're going to be talking about some of the things that you can do to prevent that. So when we start doing these kind of treatments, in my experiences, I see that family are often left with many uncertainties and stress. When I come to these meetings, there's usually a one or 2 person that comes afterwards and will tell me their story about caring for their loved one. And they always feel that sense of, did I do it right? Did I kill my husband by wanting to go on hospice too much? Or did I give him too much morphine? Did I do the right thing by doing all these? And what do you do, right? Because you don't, people are still living with their guilt. As you think back and say, did I do the right thing? During that chaotic moment, in the emergency room and the intensive care unit, all these doctors are rushing in. They said, we're going to do this. You want us to do this or not? Here, sign here. And that moment, they said, okay, sign it. And then later go, oh, I wish I didn't do that. Okay, so guilt, depression, financial concerns are often things that we see in family because they're not prepared. They didn't plan for this. But when you start talking about planning, okay, so as we look back on our life, anything important in our life we plan for. We plan for a birth of a child, we plan for a graduation, we plan for weddings, months and years ahead. We plan for our retirement, but do we plan for the end of our life when we're prepared to meet God? Which is important, which is probably the most important one of all, right? So this is why I'm going to talk about the advance directive and the POLST. How many people here have an advance directive? Okay, about half of you do. How many people have heard the POLST? Less, okay. How many people has a POLST? Good, okay. The reason why I said good, because not everyone has to have a POLST, but we need to talk about why it's so important. One of the advance directive, Patty, do we have a 5 wishes here today?
Yes.
So we have a copy back there. You're welcome to it later. But 5 wishes is one of the many advanced directives that we utilize. Patty and I, we promote the 5 wishes because it's put together by a Catholic lawyer, and they talk about what are your wishes? Who's the person who's going to make decisions for me when I can't? What kind of medical treatment I want or I don't want? How comfortable I want to be? How I want people to treat me, and what I want my loved ones to know. So this is a 5 wishes here, and it's free to you. And I like the 5 wishes is because sometimes what my loved one to know is like if I am in a hospital, I'm not doing great. I just want people to know I'm Catholic, and I like to have a priest come and give you the anointing of the sick. What's important to me. Okay, and besides what kind of flower I want at my funeral, but that's the advance directive is something that's that's something for the future. And this form here, the POLST, that I'm glad that none of you raised your hand and said I have a POLST, because the POLST is for people who has a prognosis of maybe 12 months or less if the illness follows its natural course. The POLST is a very powerful tool for people living with serious illness. Yes, you could be in palliative care, but people who are at the end of life, last year of life, because this POLST form transforms this 5 wishes into something that's very concrete, in which the paramedics can use and the doctors can use. So this form is extremely important. And it's not just about here's my wishes, and here's a bunch of check boxes, and so I'm just going to check it and we're done. No, it's really about the conversation. By having this conversation with yourself about, okay, what's important to me, speak to your loved one, your spouse, your children, speak to your doctor. It's all about the conversation, not about checking boxes. Okay? So there's some subtle differences between the advance directive and the POLST. And I'll be talking about the POLST. I'm going to spend about 5 to 6 minutes on the POLST later today. So the advance directive is for anyone older than 18. It gives you instructions for future treatment. It says something like, if my condition is incurable, irreversible, I do not want to have these treatments. Right? That's something that I'm still healthy, but this is for the future. And I'm going to point someone who's going to speak for me. And I have a story, when you pick someone who will speak for you on your behalf when you can't speak for yourself, you have to make sure that person, your child or your spouse, has the intestinal fortitude to stand up to all the pressures against them. If you have a family, your children, you have 5, 6 kids, and they live far away, there may be one child who's with you, caring for you, knowing your wishes, and the 4 or 5 others who's in other states, they visit you maybe once a year during Thanksgiving or so. So when we get sick, they get really guilty. They have all this guilt, and they're usually the one who's bashing, the one who's caring for the loved one here, and say, "Why are you stopping all this treatment?" Because it's the guilt oftentimes, even though patients may not want it. So you name a person who's going to speak for you, and who will speak for you based upon your expressed values. They're not going to make your decisions for you because it's at a whim. This is what they think they're going to do for you. I had a patient in the intensive care unit. This is a gentleman with COPD. He's got pretty bad lung disease. He goes in and out of the intensive care unit. He has to be intubated, and then we get him over the hump. He aspirates, and then after 3-4 days of antibiotics and then on a ventilator, help him breathe, he gets better, and then get him out, and he goes home. He bounces right back. The last time I saw him, he said, "Dr. Nguyen, I'm done. I don't want this anymore. I still want treatment. I'm not ready to die, but I just don't want to go in the intensive care unit with machines down my throat. I'm done." And he didn't have an advanced directive. I said, "Well, let's get an advanced directive done and maybe get a pulse done too." And I said to him, "So who's the person who's going to make decisions for you when you can't make it for yourself?" And he looks at his wife. "She will." And then I look at her and say, "You heard what your husband said. And he says that he doesn't want any more ventilator support. And what are your thoughts?" He said, "No, I want him to have vent support." So I turned around and looked at the gentleman and I said, "I think you need to find someone else, because I don't think she's going to be able to honor your wishes, right? Because it's okay not to, at some point, I don't want to be be intubated all the time in intensive care unit." So the advanced directive appoints a decision maker who's going to make decision based upon your expressed values and your preference. So that person knows what's important to you. They will speak for you when you can't speak for yourself. So that person plays a critical role, and you just can't pick someone out of the blue and say, "Here, you make decisions." No, here are my decisions. You're going to speak it for me. The pulse is for the seriously ill or frail at any age. But the surprise question is, would I be surprised for the doctors? Would I be surprised if the person's disease continues its natural progression, if this person died the next year? So the pulse is really meant for people in the last 12, 18 months of their life, because we need to have some serious discussion. Because if anything were to happen, the paramedics are the first ones to be there, and they need to make the decision right then and there. And so when they get you in the emergency room, you know what to do. So the pulse has very specific orders, and it can also assign by a decision maker. A little bit about the pulse and Catholic social teaching. Some of you may go and look at the pulse, look at it, and then you'll see that, well, the Catholic Church is against the pulse. Well, yes and no. The Church isn't against the pulse. The Church is against the pulse that doesn't allow, it just allows a one-way direction. The pulse stands for Physician Orders for Life-Sustaining Treatment. Pulsed. Physician Orders for Life-Sustaining Treatment. This is a physician order. So there's one state that has a pulse in which it has one signature, is the doctor's signature. It's my signature, if that's the way it is. So in a way, the doctor say DNR, no treatment. So that's the pulse in which the Catholic Church is against. The California pulse is very consistent with the Church's teaching because it does not contradict the Catholic principle, because it has both the clinicians and the legal decision maker in here. So the doctor isn't making a decision in a vacuum. He's having a conversation with the patient or the decision maker, and it requires two signatures. We'll talk a little bit more about that, okay? So pulse is consistent with the Church's teaching, and it's meant for people in the last year of their life. Okay, so this is what the pulse looks like. So let's talk about this. Let's look at the anatomy of the pulse. You see it's double-sided, but we're going to talk about the front side. The back side talks about, gives you instruction of what the pulse looks like. So section A. Well, before we talk about section A, you'll see that the upper left-hand corner of the pulse, this EMSA thing, this emblem there, it stands for Emergency Medical Services Authority. It just basically means it belongs to the paramedics. They will not respond to they will not follow any instruction, any written instruction, anything, except what is on this form. So it is the medical paramedics, 911, EMS, they're the ones who will respond to this and answer to this. So section A talks about CPR. So what is CPR? CPR stands for cardiopulmonary resuscitation. So if a person has no pulse and they're not breathing, what does that mean to you?
They're dead.
Cardiac arrest, they're dead. Yes, that's what it means, right? If a person has no pulse and is not breathing, this is where CPR option is, right? Do we attempt resuscitation, or we do not attempt resuscitation and allow a natural death? So when you come on scene, a person has no pulse and they're not breathing, they're not responsive, they're dead. What do? Do you apply cardiopulmonary resuscitation, or do you allow that person to die a natural death? By default, CPR is going to be rendered unless the person says no, and they have to put that on the form. Okay, so let's talk about CPR again. CPR, when a person has died a natural death, they will have no heartbeat, they're not breathing. If someone were to choose do not attempt resuscitation, which is the second box on here, okay, it does not mean do nothing. It just means that, in situations short of a full cardiac and pulmonary arrest, do something, but if I'm dead, let me die naturally. That's what CPR, that's what Section A of the Pulse talks about when you choose do not attempt resuscitation. We know that CPR is not very effective for people who are older and who are frail, who have series of disease, because it can cause harm. It doesn't work. When you look at people who are sick and frail, who are sick and frail in our society, in our community, it's usually people in the nursing home, right? They're so sick enough that they belong in a nursing home to be cared for. The success rate of CPR, what is the success rate of cardiopulmonary resuscitation on TV?
100%.
Yeah, almost 100%, right? But what is it in real life? Any guesses? Yes, 50%? 30%? Higher or lower? 20%? That's getting closer. About 17%. Across the board. Yeah, it's really CPR, 17% success. You have a better chance in the hospital because we're monitoring, we're watching you. Okay, CPR, let's talk about what does success means. CPR, success rate of CPR is about 17%. That means when someone's dead, they have no pulse, they're not breathing, but hey, CPR worked in this person. 17% of the time. What does that mean? What does success look like? Well, the person may be able to get to the emergency room, end up in an intensive care unit with a breathing tube down their throat, a machine breathing for them. And they have all 3-4 different cardiac medications running through their vein, keeping their heart alive. Miracle medicine, that is success for doctors. That person ought to be dead or should be dead, but hey, they're alive. We got their heart pumping with medications and they're breathing with the machine we give them. That's success. If success is defined as how is that person to get back to the level of health where they were before they had a cardiac arrest, that percentage becomes diminished significantly. Okay? Because when there's hypoxia, there's not enough blood to flow into your brain when your heart stops, that person will be severely impaired. They may not be able to breathe on their own after that. But I kind of tease you with the nursing home story. The sickest and most frail in our community live in a nursing home. What is the success rate for those people living in a nursing home? CPR success rate is about 1 to 2%. Wow. Yeah, it's very low. So we go, oh, we got to do everything. Well, what does that mean? Okay, 1 to 2%, but how many of those 1 to 2% that actually survived to get to the hospital ever get back to the nursing home? I think less than zero. No, not less than zero, but significantly less. It's very rare. I had a room like this when we rolled out the Pulse. Remember, Patty, about 12, 13 years ago, I had a room like this with director of nurses in nursing home. I got them all in and said, okay, let's talk about the Pulse, better do this. I asked them, so how many patients have you had in your career, where you called 911 for your love for this patient, they end up to go into the emergency room and never come back to you? I had one nurse who said, yeah, she's been a nurse like 30-something years in a nursing home. And Father, you work in a nursing home.
Yes.
What do you think? What do you see?
Yes,
None. Okay, so that's the reality. But understand though, so if we choose DNR when I'm dead, It does not mean do nothing, because this is where section B comes in of the pulse. Section B talks about, hey, I have a pulse and I'm still breathing. What are my options? Right, so you have three options. The first option is full treatment. Hey, do everything. This is what we mean by doing everything. Doing everything because I still have a pulse, I'm still breathing, but if you don't intervene, doctors and nurses and paramedics, I'm going to die. So I want everything. That means prolong my life. If I have to go to the ICU, let me go to the ICU. I need to be on a ventilator, give me a ventilator. I need a dialysis, give me dialysis. I need blood transfusion, do all that. I want all that. That's full treatment, okay? And then the other option is selective treatment. So yeah, I do want treatment, I want to live, but you know what, I'm tired. Just like my gentleman said, I don't want to go to the intensive care unit anymore. I still want treatments, I still want blood transfusion, I still want IV antibiotics, I still want, I want fluids, but heck no, no more intensive care units. That's really the difference between full treatment and selective treatment is the intensity of care. No ICU for selective treatment. And there are those who are just want to say, I'm done. I want to be comfortable. I just want to be kept comfortable. You know, if I get if I get pneumonia, I get UTI, yes, give me some antibiotics, but I don't want to go to the hospital. And if I'm sick enough, let me go on hospice and help me live at home to the best I can. And that's what we mean by comfort care. Okay, so let's put this together. Okay, what I'm sharing with you is something that most doctors struggle with. So you can understand this principle. This is a very, very important principle. But once you understand it, you go, that makes sense. Duh, right? So section A. What is section A? Can someone tell me what section A talks about?
You're alive.
The person's dead, right? The person's dead. So the person can choose, if they choose attempt resuscitation in section B, they have to pick full treatment. Right? If I want everything, then okay, let's get you CPR, let's get you full treatment. But here's a concept I want you to grasp, really important. Now let's say someone chooses do not attempt resuscitation in section A. What are there options in section B? They have multiple options in section B. Okay, you can be a DNR in section A. If I'm dead, let me die a natural death. But I can choose full treatment. I still can get full treatment. Does that make sense? If I choose DNR and I still can get full treatment, does that make sense?
Yeah.
Yeah, right, because you understand the concept. Dead. Not dead, but soon to die if you don't treat me, right? And so the patient can be DNR and be full treatment at the same time. A lot of my colleagues struggle with that in the beginning. And so I said, so this is why we need to educate our doctors and say, look, DNR does not mean do not treat. DNR does not mean do not care. DNR just means when a person's dead, allow them to die a natural death. Take care of them and take care of the family. But if they're not doing well and they have DNR written, they can still have full treatment, or they can have selective treatment, or they can focus on comfort care. Really important slide. Questions? You like it? You understand it clear?
Yeah.
Okay, this is really important, okay? So if your doctor says, you don't want to be an RN because no one's going to treat you. No, doctor. DNR just means when I'm dead, when God calls me home, just let me die naturally. But I still want treatment, full treatment. So this is where the pulse comes in, okay? All right, let's talk about section C, artificial nutrition. This is always a hot topic to talk about. You know, artificial nutrition, we talk about, we always offer food by mouth, feasible and desired. We're not withholding food and water from people. But we also know that there are other means of getting people nutrition, artificial nutrition, an NG tube, which we call a nasogastric tube, nasogastric. We give them gastrostomy tube, goes straight into their stomach. So everything is done here. But let's talk about what are the evidence of feeding tubes. What if I tell you there's no evidence that tube feedings improve comfort, survival, or functional status, or prevent aspiration for those at the end of life? We do this all the time, but there's no evidence. We do it just because we can, because someone pays for it. Okay? No evidence. Comfort, survival. What about people with, that there are other inherent risk of putting a tube in there? You pull this out within the 4 weeks. You can cause trauma, perforation, peritonitis, infections around the area, hemorrhage, ulceration, leakage, clogged tube. I'm not against tube feeding. I just want to make sure people understand the intended benefit of the tube and the potential side effect and how much are you willing to tolerate. And in our institution, we put in tubes every single day. Does it benefit for some? Absolutely. For others, I'm not sure. But here's some feeding tube scenarios. How about dementia? People with progressive dementia, they lose their ability to swallow food. They may even choke on their own saliva. With the feeding tube, it's usually generally discouraged. But even the G tube may shorten a person's life. But wait, the intention of the G tube is to give people nutrition. Isn't it meant to help people live longer? But however, it can shorten a person's life. It's because the body's already in decline. Delirium, pressure sores, and infections do occur. People still aspirate. You think that, well, I can't swallow up here, and then maybe you stick a tube down here, we'll bypass this. Smart. But people are still putting secretions. Artificial nutrition can still reflux. It goes down the lung. All the saliva you produce, people still aspirate. Yes, sir.
What about a gastrostomy tube?
That's exactly what a gastrostomy tube is. A G tube, a gastrostomy tube.
Oh, yeah.
Yeah, so, no, I'm sorry. Yeah, you're right. Gastrostomy tube or a G tube. So,
Well, but if you begin a treatment, what if you want to stop the treatment?
you can.
It's the only thing that's keeping you going nutrition.
We can, and we'll talk about that. The benefit and burden. Okay, the benefit and burden. Yes, you can do the treatment. It becomes burdensome if you're giving someone. So let's say, well, it's just too tough because the doctor's offering it to me, and I just can't imagine my level without nutrition. Just do it. Just put it in, because the Pulse has that, right? The Pulse has, you want tube feeding or not. You said, yeah, I want long-term nutrition. I want feeding tube. Other people say, well, I don't want it. I say, that's not how I want to live. And there's this thing called trial period. Do it. It's beneficial for me, do it. But what if I keep aspirating, it keeps leaking, and I'm having infections, and I'm just having recurrent? It's okay to discontinue. Yeah, the beauty of this is you're not committed to this. It's like, if it's beneficial, do it. If it's not, don't. If you're not sure, do it. If you're not sure, do it.
But, excuse me,
Yes,
you're referring mainly to end-of-life situations as far as the issue is concerned, right?
yes, I am. We're talking about end of life here.
Yeah.
We're talking about end of life. We're talking about dementia as well, which is an incurable disease. When a person gets to the point of not swallowing, then they're at the end of life. So, but however, there is useful scenarios to extend life. When people have a temporary swallowing problem, they have a stroke, right? They can't swallow, so if they can't swallow, let's give them some nutrition, right? We need to put an NG tube, nose down their stomach. If they're making some progress and that it may take a little longer, sure, let's put in a gastrostomy tube. That's good. And people with head and neck cancer, they can't eat, they can't swallow. What do? Oh, just let them starve? No, give them nutrition. Let's give them the nutrition they need. People with ALS or Lou Gehrig's disease when they can't swallow, G tube is fine. Okay, we're not withholding that from people because they're not dying. Okay, they don't have a terminal disease. Well, they're terminal, but they're not actively dying phase. And then section D deals with the signatures I talked about. I have so much to share with you. I'm going to fly through some of this stuff. So the patient's competent and able and has to write dialogue, it's okay. We talk about proportionality, right? We talk about, if people have the right to dialogue with their medical professionals to evaluate the treatment and to judge its actual proportionality in their concrete case. And to refuse treatment in such proportionality is judge lacking. So when a doctor offers you a treatment, you weigh and balance it. Say, okay, this is consistent with my wishes and my values, and it's consistent with the teaching of Catholic Church. I may want it, or I may not want it. It depends on you. It's always about the person. We'll talk about that. The well-being of the whole person must be taken into account in deciding about the therapeutic intervention or use of technology. Therapeutic procedures that are likely to cause harm or undesirable side effects can be justified only by a proportionate benefit to the patient. Okay. I'm going to use the example, the person comes in with a ruptured appendix, okay? Harm, undesirable side effect. Yeah, I'm going to put a knife in you, I'm going to cut you up, and I may perforate your bowel. I may accidentally cut your bowel when I do that. But if I don't take care of the appendix, you may die from sepsis, right? So the proportionality just makes sense. It's just a sign of consent. Let's get this out because we know we can treat this most of the time, 99% of the time. Right, so there's inherent risk involved in everything, but the benefit outweighs its intended benefit, the intended benefit outweighs the potential harm. So there's an ethical obligations to use available, effective, non-burdensome treatments. So we have the obligation to utilize available, effective, non-burdensome treatment. That's from the physician's responsibility. We have this obligation, but there's an ethical option to use or refuse treatment that is either ineffective or too burdensome in the judgment of the patient. So let's say the doctor, this patient has, let's say, metastatic lung cancer, and the doctor offers this newly treated chemotherapy. Okay, so, here we do this all the time. We're going to do, let's go ahead and start the patient with chemotherapy. But if the patient isn't responding to the chemotherapy, the doctors say, let's go ahead and try the second, the third, the fourth, or the fifth. But if the person says, I'm done. I'm getting side effects from this. I'm not responding, or the cancer is not responding to the treatment anymore. I don't want this anymore. And it's okay. You can even say no to the first treatment and say, I just can't see myself continuing this treatment. But again, it's always in the judgment of the patient, not the doctor. The doctor's role is to offer medical treatments based upon his or her learning, but it's the patient themselves who will choose those treatments based upon their choice, based upon their understanding of how the treatment can benefit them or cause further burden. So patients and family make healthcare decisions, doctors make medical decisions, two separate things. Should I say that again?
Yeah.
Okay, doctors make medical decisions. This is why we go to medical school and get medical training. The rest of the public, you make healthcare decisions based upon your values, your preference, and what you're taught. You cannot tell a doctor, I want a cardiac transplant. I want a liver transplant. So no, doctor, I can't give you a liver because you don't need it. Well, you don't need a new liver. You don't need it, okay? So you can't make a doctor do what is not needed. So what treatment counts as burden in Catholic teaching? It's always from the patient's perspective. Not the doctor's, not the loved one, not the bank, okay, not the hospital representative. It's always from the patient's perspective. If the treatment causes excessive pain, some people can tolerate pain better than others, but it's up to the patient. Major disruption of personal family life. I have patients who live here in Newport Beach, but they fly to, they fly to Sloan Kettering in New York for treatment. Well, there's disruption, but hey, they're willing to do it, great. Because maybe Sloan has a special treatment that no one else in the country has. Are they willing to do that? Great. If it's not, if it causes major disruption, they don't have to do that. It causes the treatment may cause high risk of injury and mortality. Severe dread of repugnance, great financial expenditure. Even the church teaches, look, if it becomes too expensive, financial expenditure for yourself, your family, for your community, you don't have to do it. You don't have to choose this thing if it's, as you see it, as burdensome. So this is a very important piece, but there's some common misunderstanding that I'm going to share with you. Two things. We call it the mistake of simplicity. I talk about, you should always offer these treatments, but the mistake is that the church, this is false, okay? The church requires a person to always accept treatments that are medically simple, usual, ordinary routine. Because the doctor offers it, I have to accept it because the doctor told me to. No. Misunderstand that one is obligated to accept medical treatments that are technologically simple and ubiquitous as the only factor in ethical medical decision making. What I'm saying is, we put tubes in people. Okay, we give people blood transfusion. This is normal treatment. But if it's but the person does not have to accept the treatment if they find that the treatment is burdensome for them. I live a good life. Every few weeks I'm coming here. I'm just keep bleeding out. I get transfusion. Maybe I don't want this anymore. That blood can go to someone else. I live a good life. I don't want to pursue it. They can say, I don't want it. And forgetting that the most important question is whether or not the specific treatment offers a reasonable hope of benefit or whether the treatment has excessive burden. Okay, benefit burden. The other mistake that people have is what we call myth of maintenance. You know, you have people, you have loved ones on ventilators for years. They live in this LTAC. Anyone here understand what an LTAC is? Long-term acute care. These are patients with G-tubes and trach. They go to this facility just because they're so impaired. They stay there. And sometimes there's this. When you walk into these places, sometimes we're warehousing these people that typically a lot of them will not get better. But sometimes it's the myth of maintenance, because just because we put it in there already, we can't stop it. You got to keep going. So there comes a time in which the burden becomes too much. The burden to the patient, not the caregiver. We don't want to care for these people anymore. The burden may mean, these people with tracheostomy, with a G-tube, they may get recurrent pneumonia. They may bounce back and forth to the hospital. There comes to a time to say, that's enough. No further treatment. And it's okay. Does that make sense? Okay. So that's a myth. So just because we wrongly think that church requires continued treatment for as long as it's working well. The doctors say, oh yeah, the numbers look great, but the patient doesn't, right? We're not treating numbers, we're not treating organs. We're very good at treating organs. We have specific specialists for each organ. Right, you speak to the nephrologist, and the nephrologist will say, yeah, your number looks great. But you talk to the oncologist, and the doctor oncologist may not say anything, but this person had metastatic breast cancer to their brain. Kidney looks great, but the person isn't. Okay, and the Catholic ethical principle applies to the same as starting as to stopping treatment. So it is ethically okay not to start the treatment. And it's also okay to stop the treatment when it's no longer viewed as benefiting the person. Okay.
Excuse me.
Yes, ma'am.
You said earlier that it is always the patient's decision, right?
Yes.
What happens in the scenario where you have a Catholic family and the patient is in a persistent vegetative state but not brain dead? So the patient is not able to make that decision, and yet the burden is on the family. It is also the burden on the patient, but the patient cannot make the decision. So where does the family stand in that case?
Yes, and so the question then, when you deal with someone who can't speak, let's say they're in a persistent vegetative state and they're on artificial nutrition to keep them alive, and who makes a decision for the patient? It's usually family members or a durable power attorney one. If the people don't have one, the state will make it for you. But then you always look in terms of the benefit. If the person, what did Pope John Paul II said about people in persistent vegetative state? They're not vegetables. They're still alive. They're just like in a deep sleep, but they're not responding to you. They're not dead, right? But they're not. Now we're talking about someone who has a persistent vegetative state with recurrent infections, back and forth to the hospital. There comes a time in which are we obligated to keep treating aspiration and pneumonia for these people? Or is there a point of time when said that's enough? Let's say this person in persistent vegetative state, they're bedbound, they develop a bunch of pressure sores, they have sepsis, in and out of the hospital, debridement. Is there a time when they said enough is enough? And that's up to the family to decide. Someone who can speak for the person. Oftentimes in our community, in our society, we don't talk about it. And so we have a lot of these patients who are warehoused, and we kind of keep treating them just because we can. Okay. Great question. But it's all about life. Persistent vegetative state is not a terminal state, because that person can be alive for a very long time with artificial nutrition. These folks ought to receive it. But if it becomes burdensome, their body's breaking down, they're dying, you don't have to give it to them.
And it's okay with the church.
I have two priests here. Would you agree with that, Father? They're shaking their head, yes. I didn't make this up. So anyways, so I'm going to summarize in just a few slides here. Okay, we believe that human life is a gift from God, a sacred gift that no one can dispose of at will. All persons, regardless of their medical condition, possess the inherent dignity and are worth the respect, protection, and care. So all of us are created in the image of God, and we have inherent dignity. And inherent dignity means that you are valued. You don't have to be a billionaire to have the dignity, or you have to be a dignitary to be a dignitary, right? Just, you're born a human being, you have the inherent dignity. And respect for human dignity and human life demands that we will take reasonable care of our lives. Such respect, however, does not mean that we must do everything possible to prolong physical life, especially when death is inevitable or when treatments would be too burdensome for the patient. Exactly what you said. Great question. So death is inevitable, or when treatments would be burdensome for the patient. We talk about, it's about the conversation. It's important to have an advanced directive, understand the pulse and how it's used. And we talk about the differences between palliative care, end-of-life care, and hospice care. And hospice and palliative care focus on the person, not just the disease. We look at the person behind the disease. And I'm going to end my talk by a quote from Dame Cicely Saunders. It was when I started doing hospice work nearly 30 years ago. This was my call. She says to the patient, "You matter because you are you, and you matter to the end of your life. We will do all we can not only to help you die peacefully, but also to live until you die." And so this is the role of what we are, who we are as Catholics. We help each other, the vulnerable, the weak, to help them live as well as possible. And at which time, when they die a natural death, we make sure that they have the spiritual guidance that they have, getting our priest involved for the sacraments. Okay, so I end here. Thank you.